reflexes. If we irritate the patella, it's begin to going up and down. It makes the clonic movements. It is clonus of the patella. Also may be observed of the clonus of lower limb. If with the effort flexor the lower limb, in this case begins the clonic movements, flexing and extensing. It is a result of the high exaggeration of the level of response of tendon reflexes. But this may present, clonosis may be absent. But these three cardinal symptoms, which is hyperreflexia of tendon reflexes, pyramidal hypertonia, and pathological reflexes, are observed in all cases of the central spastic palsy. So is the synkinesia, which may present and may be absent. Synkinesia is the additional movements. For example, by comment, your patient cannot move the right upper limb. So you understand he has the pulse. Now you investigate to find what type of pulse he has. And you find out that there is the hyperreflexia, increased response of brachioradial, biceps and triceps reflex. There is the pocket knife phenomena in this palsy limb of pyramidal hypertonia is present. And then you find the presence of synkinesia, which is also the symptom, which may present or may be absent in case of central palsy. The synkinesias are of three types: imitative synkinesia, coordinative, and global. Imitative. You say to make the wrist by the fingers of the hand in palsy limb. Of course he cannot make because he has palsy. And palsy is absent of any voluntary movements in this limb. Then you ask to make on the safe side by the safe hand to stretch the fingers. And you see, according to this, the fingers on the affected side of the palm of the hand sometimes has the tendency to flexor. This is imitative synkinesia. The same, if you ask to make the wrist on the non-affected side and you put your hand to the forehead of the limb, you see that the muscle tone elevated. It is the coordinated synkinesia. The muscle tone are increasing in the muscles which possibly may make this flexor movement. If muscle tone is increasing the all length of the palsy limb, it is the global synkinesia. But once more I repeat that clonosis and synkinesias may be present and may be not present in central palsy. But these three cardinal symptoms, hyperreflexia of tendon reflexes in palsy limbs, also in palsy limbs, pyramidal hypertonia and pathological reflexes are cardinal symptoms of the central palsy. The symptoms of peripheral palsy is very easy. I already told you and mentioned and easy to remember. As we say that beginning from anterior horn and then root, spinal nerve, plexus peripheral nerve, it is descending part of the reflex arc as integrated center in the anterior horn, part of the integrated center. So impulses did not come to the muscle, and you know that there is no response if the reflex, any part of reflex act is damaged. Observe the reflexia. Impulses did not come. We discussed this proprioceptive reflex or myotatic reflex to the muscle. So there is no regulation of the muscle tone. There is the atonia, decrease of the muscle tone. And from some time observed the atrophy of the muscle. So these 3A symptoms begin from this A are cardinal symptoms of the peripheral palsy. Areflexia or hyperreflexia, hypotonia or atonia, and atrophy of the muscles, muscle atrophy. These are symptoms of peripheral or placid palsy, and you can easily understand why it happens. So, as you see, the damage of this long projective tract, beginning from cortex till the muscle, may be damaged as in the system of upper motor neuron, and once more I repeat, it's the distance from cortex till the anterior horn, as in lower motor neuron system, it's the distance from anterior horn till the muscle. And in both cases will be observed absence of voluntary movements, which is called palsy or paralysis. But if there is the damage in the system of the upper motor neuron, in this case observed the central palsy. If there is damage in lower motor neuron system, in this case also observe the palsy, but this palsy will be peripheral or flaccid palsy. Now, as I usually told you, if of course you graduate from university and get the diploma of the doctor, you have to treat the patients. But in some cases, you also have make the expert decision, which is necessary from police or to some insurance office and so on. So maybe somebody teach your patient to move, for example, left limbs, and by command don't make the movement of the right limbs. To get profit from this, he imitate that he has palsy. How will you find that he is simulating, that he really did not have the palsy? You must remember that in the nature are only two types of palsy. Palsy may be central or palsy may be peripheral. If this patient or person whom I examine and by command did not move the limbs, you must find in these palsy limbs or symptoms of central palsy, which are increase of the response in this palsy limb. It is the hyperreflexia of these tendon reflexes. Or in this palsy limb, you must find the elevating of the muscle tone, pyramidal hypertonia. Or you must find the pathological reflexes. If you did not find these clinical symptoms, then you think that maybe he has peripheral palsy, because in both cases there is absence of voluntary movements. You find that reflexes are present, so there is no areflexia. The muscle tone is not changed, it's normal, so there is not hypertonia, and you cannot find the atrophy of the muscles. So this person is simulated. He did not want to produce this movement, but he did not have the palsy because there is no clinical symptoms, no of central palsy, no clinical symptoms of peripheral palsy. So he is aggravated, he is simulated, because you know that in the nature are only two types of the pulse. So you see, if you have the knowledge of the normal neuroanatomy and You remember which structures and how these tracts are passing and where they pass the definite structures of the brain and the spinal cord. It makes you possible to detect and to find out not only the palsy but other pathological symptoms or signs which affect the nervous system. And one thing about the cortical bulbar tract and innervation of motor nucleus of the cranial nerves. Once more, I want to repeat that the motor nucleus, which are situated at the beginning from the motor nucleus of the trigeminal nerve, is in lower part of the pons, and facial nerve also, which is also in the lower part of the pons, and motor nucleus of 9, 10, 11, and 12 cranial nerves has the specific innervation, except the half nucleus of facial nerve and nucleus of hypoglossal nerve. All nucleus on the both sides, left and right, get the cortical impulses from the inferior part of the precentral gyrus from the both hemispheres. So these motor nucleus have the double cortical innervation. According to this, the damage of this cortical nuclear tract on one side did not result in the central palsy of fifth, upper part of the facial nerve, and 9, 10, and 11 cranial nerves. It results only in central palsy of half facial nerve, because you remember that lower part of the nuclear facial nerve has the contralateral innervation and central palsy of hypoglossal nerve. According to the central palsy of the half facial nerve, on the opposite side from the process will be observed the drooping of the corner of the mouth down, because lower part of the muscles of the face is affected. And if you ask the patient to show the tongue, it deviates from the middle line from the opposite side of the process. If left tract is damaged, the tongue will deviate it on the right side. How realize that it is the central palsy and not peripheral? You remember that symptoms of peripheral palsy is one of the symptoms, atrophy. Yes? If you see that there is no atrophy on this half of the tongue, in this case, you will be sure that it's not peripheral palsy, that it is the central palsy of the hypoglossal nerve. So this was the system which I will discuss with you, and by this I finish. And to those students from Monday which have the practical classes, I advise you not be the lazy bones, and during this weekend find the time not only to study material which you have to prepare for the next week, but also carefully once more listen the lecture, find in the books and in other sources this somatosensory system and motor system, because it will help you when we go to the practical discussion in the classes more easily to accept this material, because beginning from the following week we'll begin to find out the concrete localization of pathological process. And to identify the localization of the pathological process, you must have the strict knowledge of the normal neuroanatomy of these pathways and structures, which are main structures of this somatosensory and motor system. Now, I wish you a good weekend, and we'll meet with the students who are not in Georgia. During the online lectures to others, we meet in our practical classes.
Vidinalo da Professor.
Kaihar.
Mukande.